Great. So today's webinar, titled Biomarker Legislation, a collaborative discussion on rationale, requirements, and compliance best practices, is brought to us by Myriad Genetics. Myriad Genetics has been a long-time MHPA partner and supporter of both the association and our health plan members. I want to thank the entire Myriad team for organizing today's session. With that, I'll go ahead and toss things over to Paul Shives, Myriad's Vice President of Government Affairs, to go ahead and get started.
Great, Eric. Thanks. We really appreciate the opportunity through MHPA to bring together a great group of experts here to really address the issue of biomarker laws today. It's been a hot issue. I know I've been at conferences and they've spent half a day or more on it, even when they're not focused just on state biomarker laws. So I know it's a hot topic and something that folks are wondering about where things are in the states and maybe some of the implementation challenges. So you can see here we have our agenda today. I'll introduce our panelists in a little bit more detail shortly, but by the American Cancer Society, Concert, and also Hogan Lovells. So really diverse panel here to talk about experience with biomarker laws. We go to the next slide. I wanted to give just a brief overview of Myriad. So Myriad is one of the oldest labs in the country that really focus on genetic testing and genetic assessment to assess disease risk, predict progression, and guide treatment. We have 3 different business units in oncology, mental health, and women's health. And you can see some of our product offerings there. To date, we have supported over 5 million patients and have had over 100,000 providers order our tests. So we have a real interest in reaching patients with this testing. And I think a lot of what we're going to talk about today with these biomarker laws, some of the rationale for why they were passed in the first place, and how we can all work together to make sure that patients are benefiting from the best testing that's out there. So we will talk about that kind of importance of biomarker testing. We'll talk about a lot of things in the States. What I wanted to do first, we have some interaction here. So a poll question that we wanted to pull up. So first, just if everyone could answer, how familiar are you with biomarker legislation? Are you not at all familiar, know some of the details, or very familiar? We'll give a moment for folks to answer that. While folks are answering, let's look at the results here. So it's good that we have some familiarity here, some that are very familiar. So look forward to through your questions or through what you garner from this, any sort of input that you can provide. I know there's a lot of states, a lot of laws, a lot of biomarkers. There's a lot of issues. I always like to refer to the old Donald Rumsfeld's known unknowns, unknown knowns, et cetera. I know there's always known unknowns. So we'd love to hear from you in the Q&A session at the end, or of course, you're happy to follow up with any of us, separately after the webinar for any questions. We can move to the next slide. So, Myriad has been working with state Medicaid programs and Medicaid health plans across the country. And we recognize there's a lot of state laws that have been passed, right? So we have 21 state laws that have been enacted that require coverage of biomarker testing. There's some variation in those, and we'll have some comments from the panelists on those variations and how they came about. And then in 16 states, they are considering. So we really are getting across the country here that the effort that the American Cancer Society has put behind getting these state laws passed has been tremendous, and it really is creating more opportunities to reach patients with this type of testing. Let me ask the second poll question before I get into introducing our speakers and topics. So you can see the map. Are you in a state where a biomarker law is in effect or expected, or has it been passed, or is it being expected or no? We're just trying to get a sense for where folks on the webinar are coming from geographically. While we're answering that, I'm going to go ahead and introduce our panelists. We can move to that slide. So first, we're joined by Hillary G. Gettner, is the Director of State and Local Campaigns for the American Cancer Society Cancer Action Network, where she leads efforts to improve access to biomarker testing, clinical trials, fertility preservation, and other healthcare issues. Prior to this role, she served as the Kansas Government Relations Director for ACS-CAN and as Director for Health Policy at Kansas Action for Children. So I've been on a couple of panels with Hillary, and she's been a great partner on some of these efforts. So I look forward to hearing Hillary's comments. We have Jillian Hooker, PhD, who is the Chief Scientific Officer at Concert, a Nashville-based healthcare technology company, where she leads the development of clinical content and tools to improve diagnostic testing management for health insurers, hospitals, and policymakers. She also chairs the Tennessee Rare Disease Advisory Council and serves as a member of the CMS Clinical Lab Fee Schedule Advisory Panel. Of note, she is a past president of the National Society of Genetic Counselors. So great background and expertise from Jillian, both in her current role and in the past on providing some expertise here on biomarker testing and how they fit into the ecosystem and how they're going to interact with these biomarker laws. And lastly, we have Brian Carey from Hogan Lovells. Brian has advised life sciences and healthcare companies on complex regulatory and legislative health policy matters for over 2 decades. I've known Brian for almost that long. Having advocated before the U.S. Department of Health and Human Services, the Centers for Medicaid and Medicaid Services, and the United States Congress. Brian uses his extensive expertise to advise clients on complex coverage and payment and compliance matters. So just a great panel. And we can revisit this question on where folks are before we jump in here. So it looks like about half are already in a state where the law is in effect. Probably lines up with your familiarity in the first question, because you may have been dealing with these. So I hope you were able to take something out of today's conversation and help to move forward on where we get to on implementation of these laws. Some where it's under consideration, it looks like we have 33% who are not in a state. And so, there are, I think Hillary will speak to this, but I don't think we're stopping, the effort stops at 20 and 16. So one day these biomarker laws may be under consideration in your state if you're in a state where they are not now. So if we could just jump in, again, I've already introduced Hillary, and she's going to provide some comments from the American Cancer Society Cancer Action Network's perspective. Hillary?
Great. Thank you so much, Paul. If we could go to the next slide. Just kind of building on what Paul shared, biomarkers are something that can be measured in your body, and this is all about matching patients with the right treatment at the right time. In cancer care, biomarkers are often gene mutations or protein expression, but this is not just about cancer. Biomarker testing is used in many other disease areas, and lots of exciting research happening in other areas as well. Next slide. So kind of why are we doing this? What's the reasoning behind ACS-CAN and other patient and provider groups' work to expand access to biomarker testing? Unfortunately, we see a lot of the same disparities in access to biomarker testing that we see across the healthcare system. So patients who are Black, are older, insured through Medicaid, have lower incomes, or are receiving care in a community setting as opposed to an academic medical center are all less likely to benefit from biomarker testing. And as biomarker testing and biomarker-informed treatments become more available and more important in improving outcomes from cancer and other diseases, we could see the disparities that already exist in cancer survival and cancer outcomes increase as treatments become more effective and based on biomarker testing. Next slide. One of the barriers, though not the only barrier, but one of the barriers to patient access to proven and necessary biomarker testing is that insurance doesn't always cover the testing that patients need. This is something that providers report experiencing challenges with. Then on the next slide, this is also something that patients experience as well. And this lack of insurance coverage contributes to the disparities we see by not only insurance type, but also education level, race, income, particularly if patients are less concerned about being able not having the testing covered by their insurance, if they need to advocate for that coverage or take the risk that they would be hit with a bill to pay out of pocket. So the goal with the policy is to align insurance across coverage policies across different plans, because many insurers are covering some or much of this testing already, but there are big disparities between different plans and different patients. Next slide. So we worked together with a large group of patient and provider organizations to develop some language to align insurance coverage, including Medicaid, with the latest evidence so that the policies for coverage keep pace with the science and advances in biomarker testing and biomarker-driven treatment. So we'll get into a little bit of the variation state to state, but largely these laws are fairly consistent across the country, looking at coverage of biomarker testing for the purposes of diagnosis, treatment, appropriate management, or ongoing monitoring of a disease or condition. This is not specific to cancer. It doesn't have any stage limitations. When that testing is supported by these types of sources of evidence. So FDA approved or cleared tests, labeled indications and warnings on FDA approved drugs, national coverage determinations and local coverage determinations for Medicare, as well as nationally recognized clinical practice guidelines. So the intention here is that testing that is supported by at least one of these criteria would be covered for these purposes. And importantly, screening of a general population, screening of asymptomatic individuals is not included in the purposes here. This is really about informing treatment for a disease or condition that has already developed. Next slide. So this looks a little similar to Paul's slide, but this just shows where laws have passed. So the red states have laws that apply to both state-regulated private plans as well as Medicaid. The yellow states took more of a piecemeal approach. So in Arkansas and Colorado and Louisiana, those laws apply to private plans. Florida and Connecticut passed Medicaid or Medicaid and state employee health plan only laws first. And then the blue states have legislation under consideration this year. And with that, I will hand it over to Jillian.
Thanks, Hillary. I'm going to talk a little bit about the work that we've been doing at Concert as a health IT company, providing reference policies to health plans to help them understand the biomarker laws in their states and think through what that means from a policy perspective. So to go to the next slide, please. What Concert has been doing for several years now is developing policies that are designed for efficient and consistent use by health plans in making coverage and reimbursement decisions. We design these in a highly structured way. We're doing it with an eye towards transparency, automation, and evidence-based policies that are up to date with guidelines. There's a QR code here if anybody wanted to go check out our policies. They're publicly available on our website. We, as an organization, don't have either an official endorsement or opposition of the biomarker bills, but really have been working in places where the bills are in place to understand what they mean. And we'll get into more of that later. We're not lawyers. I'm glad Brian's here to be that perspective, but there are elements of the laws that get into a lot of the technical details of what different policies mean. And that's really where our expertise has fallen. If you go to the next slide, I lay out really how we think through this generally in terms of how we think through policy development, but then also the elements of it that do intersect with biomarker laws. So you don't make a policy usually for every single test on the market. That would be cost prohibitive and would take resources beyond what is actually needed to manage most tests. But generally, policy is made in spaces where there's sufficient spend, volume, and a potential for misuse of a test or unnecessary use of tests that the policy guidance is warranted for the health plans to use in making decisions, and for providers and health plan members to know what's actually covered and what's not. So we do an initial review just to say, is there a reason to develop policy? And we have from the get-go always been guideline based wherever possible. And that comes from a real philosophical mindset that it's a tricky thing to put providers in a place where they have to choose between following the society guidelines that are intended to set standards for practice and what may be covered. And I think that manifests sometimes in some of the variation that Hillary referenced around the variable coverage landscape out there. So we have always been really first and foremost guideline based in our policy development, and we publish policies twice a year. That's too often for some plans and not enough to keep up with the changes in some guidelines. We ask for every policy we develop, are there evidence-based guidelines that do not conflict in any way with guidance from either CMS in the form of LCDs, NCDs, or FDA? And if the answer is yes, then we develop policies that are aligned with guidelines. In cases where there aren't guidelines or in cases where guidelines conflict with available guidance, then we're digging into the evidence to say, what's the most up-to-date, what's the most evidence-based, how do we factor in these different sources to develop clear, objective policies. And then in the small number of cases where that guidance is not available from any of those sources, we do systematic evidence reviews of the primary literature. In all cases, we find it necessary to support any policies we developed with the primary literature. In cases where there's no policy, generally those tests are getting assigned to general policies for medical necessity review. So as we've worked with states across biomarker laws, you can go to the next slide. We've had a number of areas that have been particularly challenging to tackle, and I think we can get into that in the discussion later. Questions have come up along the lines of, like, how do you apply LCDs to pediatric populations? What do you do with FDA-approved tests that may not have clear guidance for when they should be ordered or how often they should be ordered? There's some ambiguities in there that have been tricky. But I would say the biggest area of ambiguity that I wanted to call out, and partly because it's particularly timely, is around the guidelines that are available. I believe that the guideline landscape is maturing. And as a testament to this, I wanted to call out a workshop that was held last fall by the National Academies to look specifically at guidelines in genomic testing. And actually, just like 2 or 3 hours ago, they made the final report from this workshop available. So you can go to the National Academies website and read that report. But I really was honored to be able to participate last fall in this workshop and talk through what some of the challenges are in terms of making policy off of guidelines. And I think that's really relevant to this discussion today, is that there are guidelines that are written sometimes with intentionally vague language to preserve the practice of medicine, but that's really hard when you have to turn that into policy and figure out what that language was intended to mean. There are guidelines where it's not entirely clear what audience that they were written for, if they were written for the providers who practice or the payers who make policy or other folks. And so that's something that's hard to parse. And then, as I mentioned earlier, or sort of alluded to, there's wide variability in how often guidelines get updated and published. There are organizations, NCCN, I think, updated the lung cancer guideline 11 times last year. And so that's just a remarkable pace of change in guidelines. Other guidelines that are still active, but haven't been reaffirmed in over a decade. So I think some of these things, I hope, will continue to get better and will certainly help with implementation. But as I said, I'm happy to get into any more of these challenges later. But I think first we're going to hear from Brian Carey more of the details about the legal elements of these bills.
Thank you very much. And thank you to MHPA for organizing this. I think it's great to get everybody together, and really a big thank you to Hillary, who's really led a lot of the work at the states that have made these laws possible, and then Gillian doing the enormous efforts to translate these laws and policies into specific coverage. And I'm going to try to pick up with some of the specific issues we've seen coming up at individual states. Some of the issues are common across multiple states. Other ones are very specific to individual laws, and then try to give a little bit more of an overview of what are some of the sources of medical and scientific evidence that the biomarker statutes look to, particularly local coverage policies and Medicare national coverage policies. And now I go to the next slide, or I think we've already teed this up, but just to say there has been an enormous effort across 20 plus states now, and we're continuing to see other state laws being considered and introduced around the country. So great work to all the groups that have been working on those. If we go to the next slide, I think we've already shared the map, and one point I'll get into is talking about which states are both public payers and private payers for this audience. And firstly, all the states include the public payers Medicaid programs, with the exception of Colorado, Arkansas, and Louisiana. Go to the next slide. And I think this recaps a little bit of what Hilary was saying, but we still continue to see a lot of activity in 2024. Now in 2025, we've also seen, in addition to some of the broader biomarker laws, individual states have looked at, specific laws covering specific technologies within biomarker genetic testing. We can go to the next slide. So many of the statutes, include similar, terminology, and at the core of all these laws really is the definitions for biomarkers. And I think these definitions are pretty common across the laws, but there have been a lot of questions during the implementation because these are very, very novel technologies. Sometimes these tests are only performed by a single independent lab. They're laboratory developed tests. And so based on the FDA regulations, they can only be offered by one test. And they include, many different tests that look at only single biomarkers. We also have tests that look at, multiple different biomarkers and include algorithms, and then tests that also are sequencing the whole genome. So it includes a lot of different tests, even though we just generally throw everything under the one definition of biomarker. But many of these are very, complex tests. So we're going from single gene mutations to tests that are looking at hundreds of different analytes and using an algorithm to come up with some type of predictive risk score. Go to the next slide. So one of the key issues we're going to talk about today is, how do these laws define which tests are eligible for coverage? I just talked about that the definition of biomarkers is very broad. And so the legislation is, in most states, is very specific, that it sets out criteria for what are the types of categories of tests that would be covered. And it does that by looking at different evidentiary requirements. And I think Hilary and Jillian touched on this a little bit. The biomarkers set out what are the types of evidence that one would want to look for if you were doing an external validation of a test. And so, they look at, is the test cleared or approved by the FDA? The FDA reviews things for analytical and clinical validity. Has it been determined by the FDA? That's one category. That's an external validator. Another big external validator is the Medicare program. The Medicare is the largest health insurance program, although the Medicaid programs combined may be larger than Medicare. But Medicare, as an individual entity, develops both national coverage determinations and local coverage determinations, which we'll talk about more. But those are external assessments of evidence and look both at analytical and clinical validity, but also look at clinical utility. And then there are nationally recognized guidelines, big groups like the National Comprehensive Cancer Network guidelines or professional society guidelines. So these are all external validators that the law does look to identify whether a test is viewed as reasonable and necessary. We go to the next slide. So, building on that point, a lot of times questions we get are, health plans, and when Gillian is working with her colleagues and others, I mean, you're looking at a number of different issues. You're looking at clinical utility issues. Does this test help the physician make medical determinations? And you're looking at, medical necessity issues. Is this test appropriate for Brian? It would be appropriate for someone else, but maybe Brian doesn't meet those criteria. And sometimes with the biomarker laws, we hear that these two concepts are getting a little bit conflated, and it's causing some confusion. So, the way most of the biomarker laws are written is they really look to see if there's a category of evidence, one of these external validators, that the test meets. And if it does, that generally shows that there's medical and scientific evidence of clinical utility. And the test is of the type of test that's eligible to be covered. Then the health plan still would have to look at whether an individual patient, meets that medically necessary criteria. But it's not that there are two separate determinations that even if the plan has medical and scientific evidence, if the test has medical and scientific evidence, that the plan can still say, well, we're going to make our own medical necessity determination as sort of a matter of broader policy, not on an individual, specific patient. And so that's a question that sort of comes up of, really how much discretion does a plan have to ignore the categories that are in the law and make some type of separate medical necessity determination broadly for the test. And we'll get into that, I think, with some more of the questions and specific examples. If we go to the next slide, this is another, question I think we'll get into in a lot more detail. So many of these biomarker tests, one of the categories that they're relying on to meet the statutes is that there is an established medical policy from one of the Medicare contractors. So they're called local coverage determinations, LCDs. They're made by Medicare administrative contractors who work for CMS. Many of these Medicare administrative contractors are commercial insurance companies, Blues plans, or others who have government subsidiaries that have a Medicare line of work. And one of the things that comes up is, as I noted, many of these novel cancer tests are only performed by one lab. So all patient samples for the whole country, whether you're in Texas or Florida, they all get sent to that one lab. And that one lab bills their one Medicare contractor. And so many times we'll have implementation questions come up of a patient is in Rhode Island and the lab is located in California. And there'll be a question of which Medicare contractor policy applies. And if we go to the next slide, this just gives a little bit of the map of how the Medicare program, is divided up. And as you can see in the blue states, there's a large number of Medicare contractors who all participate in this program that's called the MolDX, the Molecular Diagnostics, program. And if a laboratory is located in one of those states, the MolDX program sets the Medicare policy for the whole country, regardless of where the patient is located. And the lab bills that one Medicare contractor, and that's the policy that applies. And Medicare Advantage plans are required to follow that policy, regardless of where they're located. And under the biomarker law, the states and plans in those states where the biomarker law is would also follow this policy that's established by the Medicare contractor where the lab is located. So I know that's a mouthful. I had a hard time getting it out myself. So we'll drill down that a little bit more in the Q&A. If we go to the next slide. Something else that comes up quite a bit is, obviously there's, a few parts to the reimbursement issue. One is coverage, is this medically appropriate for the patient? The second is payment, and what is the payment rate going to be? And the biomarker statutes are focused on medical and scientific evidence. They're not focused on payment. They don't implicate any of the payment determinations. So many times a question will come up, a test is covered because of the biomarker statute, but the payment may be really low, or the payment, could even be zero. And so could something that gets paid some nominal amount, really be covered? And so this is an area that's come up with, a number of labs, and there are some, different laws that include independent dispute resolution and, appealing out-of-network claims for payment, and, those types of issues can come up. But as a general matter, the biomarker laws are not addressing payment, and they also don't address prior authorization. So we have seen the scenario where a test may meet the biomarker law eligibility criteria, and then there's a lot of prior authorization, document requests. And where that gets really complex is the laboratory is the performing provider, but the oncologist is the ordering provider for the physician. And some plans may say the ordering provider, the person who orders the test, is the one who has to fill out the prior authorization and submit the documentation, even though the laboratory is the one performing the test. And so, getting that information, getting through the prior authorization, having the doctor, have to go through that for a service they're not performing or billing. And it may even be with, down the road that the test is performed, and the doctor, doesn't really have a, relationship with the laboratory. So getting those prior authorizations can be a challenge. We'll go to the next slide. I think I want to be, mindful of the time here. So I'll check with my panelists and the moderators to see how much we want to get into each of these slides and in detail. I know we have a lot of folks on from the individual states. So that's great. Everybody could participate. I think we have as a 3 or 4 states, just as sort of a case study to show how the states are similar in some of their language, and then maybe are a little bit different in the terms of the way they're going about implementing guidance and addressing some of these questions that Hillary and Gillian have raised. So, Arizona, if we look at Arizona, Arizona does have a broad biomarker statute. It does look to whether the tests are approved by the FDA or have a Medicare coverage policy or are in guidelines. In Arizona, Medicaid has been going through a guidance process for plans and providers, which is very helpful. There was an initial guidance last fall, and that was proposed, and there were a lot of comments on that. And based on the comments, Arizona went back and put out a new proposed guidance that really addresses a lot of the questions, we're getting on this call, and is, very helpful for everybody to have that kind of guidance. So we appreciate it. If we go to next slide, I think we have another example. Indiana just came out, with some guidance. So Indiana had done a lot of guidance in 2024. They've also put out some additional guidance this year. And the Indiana guidance is helpful in that it lists specific tests by CPT code. So Indiana has actually, gone and looked, see which tests are going to have some of this medical and scientific evidence, so they would meet the biomarker law, and then they put that in their guidance. And I think that's very helpful for everybody to, understand which tests, meet it. And there's some process where if you see a code that's not on that list, you would be able to go and, provide some evidence and say it meets the criteria and should be added to the list. Go to the next slide. California is another interesting one, and on this there is some guidance that came out from the Medi-Cal, the Medicaid program. But what I wanted to raise here is this issue of the Medicare coverage decisions. So in that second bullet, it says the LCD must be made for the Medicare administrative contractor, for California. And I think that's, caused some question because you may have a lab that the only lab that performs the test is located in Texas. And so any patient in California, their specimens get sent to Texas, and the Texas lab bills its Medicare contractor, and it is a different contractor than California. And so I think people have kind of read that to mean made by a Medicare administrative contractor for California that would cover the patient in California for this test. And many times that will be a contractor not located in California, just based on where the lab is. But that's how technical this really gets when you get into it. Maybe go one more slide, then we can open it up. So another, big important state, Texas. Texas has a law, very similar to the other laws. I think one issue with the Texas law is the Texas law has two different sections. It has a section dealing with medical and scientific evidence. That's what we've been talking about. They're covered by approved by the FDA, covered by Medicare in guidelines, very similar to other states. It has a second section that talks about clinical utility. And so it sort of looks like when you're looking at the statute, it's a two-part test. You have to have medical and scientific evidence, and then you have to have clinical utility. And sometimes that's assessed as two parts, and that you meet the first part, but you don't meet the second. But really, if you look closely at the language in Texas, the clinical utility is very defined in a very objective way. And it really just refers back to the medical and scientific evidence. So again, the medical and scientific evidence is the threshold. If you have that under the law, that is an indication of clinical utility. It's not that there's some separate tech assessment being done that you have to meet. It really refers back to the same medical and scientific evidence. But that's something that's raised a lot of questions. We know Texas Medicaid has put out some guidance. The Texas Division of Insurance, TDI, I think has been putting out some guidance to some of the plans on how to implement it. So we'll continue to watch that. Work with labs in Texas on that implementation. And then I think we have one last slide here. Then we have Illinois. So this is just slightly different statute, where in Illinois, the medical and scientific evidence looks for a national coverage determination by Medicare. And so that's kind of raised a lot of questions where, as we described, many labs will go to their local Medicare contractor, but all of their claims go to the local Medicare contractor. So that decision does apply nationally. So in effect, it is a national decision. There aren't multiple different decisions for Medicare. There's just one. It's from a local Medicare contractor. And I know that issue has come up and caused some questions among how you assess that when there's only one lab and they submit all their claims to Medicare, but the decision is made at the local level and applies nationally. So very, very technical stuff. I'll turn it back over to Paul to sort of open up questions to the group and get into the Q&A.
Yeah, great. Thanks, Brian, and thanks to Hillary and Jillian. Those were great walkthrough of some of the different perspectives we have here on the panel for biomarker law implementation. I'll just say you're not imagining things. I didn't have glasses in my opening remarks, as Hillary knows from 2 weeks ago on a panel and a presentation that I gave. I can't seem to remember to put them on. I'm new to glasses, and then I can't see anything, and then realize I need to put my glasses on. So, anywho, first question's for you, Hillary. I wanted to ask, how did ACS can think through what disease states would or would not be included in the scope of the legislation, with respect to maybe, disease and treatment and management versus screening, but then also just, different disease indications. If you could make some comments as to, I think a lot of times because the Cancer Society drove a lot of this model legislation, there has been some perception that it's been limited to cancer, right? And that's not the case. If you could walk us through how you'll get there.
Yeah. So the legislation grew out of research and a white paper we had done on kind of the role of biomarker testing and what barriers patients are facing in access to appropriate biomarker testing. But the language was developed in a very collaborative way with many patient and provider perspectives and written to be consistent with the evidence across disease states. So, with the exception of Nevada, which was significantly altered, kind of, and ultimately all of the patient and provider groups that were supporting that legislation withdrew their support. But all the other states have now passed broad language that applies to any disease or condition for the specified purposes of diagnosis, treatment, appropriate management, and ongoing monitoring when the evidence criteria is met. And that's in part because we're doing this in coalition with many, many groups, the Alzheimer's Association, the ALS Association, and preeclampsia, the Michael J. Fox Foundation for Parkinson's, because there are many different current applications and others in development, and also due in part to more effective and precise treatments, cancer patients are living longer and better after a diagnosis and don't only have cancer. So cancer patients are dealing with many comorbidities, often anxiety, depression, pregnancy, Alzheimer's, heart disease, rare diseases. And so those other applications of biomarker testing are also important to our constituents of cancer patients and survivors.
Yeah, great, Hillary. Thanks. I mean, as you saw from Myriad's offerings, we offer biomarker testing across a number of different disease states. Most of the effort that we put in the states is making sure our mental health pharmacogenomics, which is clearly within the law, is recognized as part of that. So we've appreciated the efforts by the American Cancer Society to recognize the need in other disease states, both for patients that are being treated for cancer, but also across the board. So thank you. Brian, question for you. And I also just wanted to encourage folks, we'll do a couple more questions and then move on to those that have been submitted through Q&A. So if you have any more, please type them into the Q&A feature. Brian, within the legislation, local coverage determinations are included as an evidentiary bar, and you talked some about this in the MolDX program, et cetera. If you could kind of drill into a little bit on how that works from a standpoint within the MolDX program, especially, but even just more generally with LCDs, that there is a covered LCD coverage policy, and there are also billing articles and kind of the interplay between those. It might be educational for folks who are maybe looking to an LCD to look at implementation and compliance with the law, but maybe not understanding where the things sit that they should be looking at to really, for it to make sense to them, like what test.
Yeah, definitely. I mean, I think this is sort of the number one implementation issue we've seen coming up with plans in states around the country, that the way Medicare operates is Medicare is the national federal program, but the bulk of all Medicare decisions are made regionally by these Medicare administrative contractors who operate under a contract from Medicare, and some are owned by Blue Cross of South Carolina, some by Blue Cross of Florida, Blue Cross of North Dakota, Anthem. They're all separate groups, and they develop their own policies. And so if you look at the genetic testing space, virtually no policies are at the national level. There's a national policy for colorectal screening tests like a Cologuard. There's one for next-gen sequencing for advanced cancers. But most of all the decisions for all the tests are done at the local level, from the single mutation tests up to the algorithmic tests. And those decisions are made based on where the lab is located. And that is unique for laboratory medicine. For something like drugs and biologics, it's where the patient's located. So in California, they may have one policy for which cancer drugs are covered. Florida may have a slightly different policy, so patients are being treated differently. For laboratory testing, because the lab is in one location and the sample goes to that lab, the Medicare rule is if the lab is only located in one state, that policy applies nationally. And then as Paul said, there's a lot of tests out there. And some of these policies are sort of umbrella policies that broadly define, what is covered. And then the specific test names and specific codes are listed in an associated article. So it does take a little bit of sleuthing and detective work by anyone involved to sort of piece this all together. You have to see where the lab's located, then go and check to see, is there a coverage policy? Check the policy, then see, is the test included in the policy? If it's not included in the policy, it might be in the article. And so, pulling all that together and finding those sources of information, has been a challenge, and something I know, labs have worked with, and ACS has worked with, plans on communicating that. And then the last piece of it is just because this is such a complex area, and you did have multiple regions duplicating the same work. 4 to 5 of the regions combined together to form this MolDX program, and basically said, we're going to review all these tests together. It's just going to be more efficient. We'll have more expertise. We're going to kind of pool our resources. And so they developed one policy, and it applies in 27, 28 states of the country. But that can also be a little confusing as well, because sometimes it looks like that policy was developed in another state than where the lab is located, and that lab's Medicare contractor then adopted that policy. So also explaining that to many of the plans and Medicaid programs has, been a little bit confusing, as these laws got implemented.
Yeah, thanks, Brian. That's helpful context. Maybe a question for you, Jillian. Hillary had mentioned that, many plans are covering some biomarker tests, but that there was a need to try and ensure more consistent coverage. That's some of the reason for why the biomarker laws came about. Curious about your experience as you started to delve in and create these policies, biomarker compliant policies, how that interaction was with the policies you already had. You just see a lot of differences. And then two, with your customers, what level of understanding did they have kind of going in as you were presenting these to them, and what issues did you run into most commonly along the way?
Sure. Yeah, I think when we first sort of looked at the language of the bills, we were pretty overwhelmed for all the reasons Brian just mentioned, like thinking about the thousands and thousands of documents that somebody would have to review to ensure that their policies were up to date and aligned, and the rapid pace of change. There's so many new tests, so many new policies coming out all the time. What saved us was exactly our philosophy from the beginning, that guideline alignment was so important. And so when we actually dove into it and found that most of the time, if you're keeping up with guidelines, there wasn't major cause for change. Where we did really kind of get hung up was in all of the many documents around the LCDs and which tests are covered and which are not, particularly when there's umbrella LCDs. The coding system today is not granular enough in many cases to identify which tests are which. And I don't think, you probably got this a little bit from my introduction too, I don't think manual solutions to do a manual review of every single claim that comes through just to see what test was ordered are really the right answer today. And there's a lot of friction in the system, which could be solved with future legislation potentially. But I do think when it comes to the health plans, it took a lot of collaboration with the health plans that we work with. So I mentioned earlier, we develop reference policies that the plans then adopt as their own policies. So as a company that's not a delegated entity, we're giving them these policies to reference and the evidence that informs those. And in the states with biomarkers, we had to sit down with their compliance and their legal teams, because those folks are really the expert in those states. Many of the plans we work with are regional or state level plans who take those state laws very seriously, and certainly make every effort to understand and align with the intent of those laws. And so it was helpful for us to learn from them how they thought about these policies, how they thought about the language in the policy, how it compared to other policies they'd had to implement in the past. And then where they needed help was really in understanding both of the sort of technical elements of what's a biomarker to this webinar, what falls under that, which tests would this apply to, and then in the landscape of like which guidelines should we be looking at, what falls under this, where do we find these LCDs, how do we align these LCDs, many of the questions that Brian addressed, of folks really just trying to understand the landscape there. So it took, I guess my punchline on that would be that it really took a team approach of the legal and compliance teams working together with the clinical teams to find a strategy that would really work.
They're great. Thanks, Jillian. So we're going to move on to our Q&A. We've had a number of questions that have come in. We only have 9 minutes left in our webinar, so I'm going to ask our panelists to be concise so we can try to get to everyone. But at the same time, these are great questions, and I want us to address them. I'm going to try to combine 3 of the questions into one question. So first, if we could just speak to, there was a question that does medical necessity determination supersede all other biomarker testing requirements for all states? So I think, Brian, you touched on that a little bit, but and maybe Hillary as well, but we could kind of address that. And then this question also probably for you, Brian, being that, what is the general litigation landscape around these laws currently? Are either plans challenging the laws or labs and states with legal action against plans compliance? And then I'm going to try to fold also the third part of this in, which is, for state laws that have been passed, what entities are enforcing that tests are being covered as outlined under the law? So is it the states themselves? What elements is it? The labs, self-regulation by payers, et cetera. So we could try to hit those 3 topics here and some answers. That'd be great.
Well, I can sort of tee up the first part and then defer to Jillian and Hillary. So, as I see it, the medical scientific evidence requirements sort of establish whether the test is covered or not. And medical necessity would really be towards the individual patient. Sometimes we see medical necessity being used to establish non-coverage policies that the test is experimental and investigational, even though it meets the medical and scientific evidence. And I think that's not really consistent with the biomarker laws.
Yeah, I would agree with that. Medical necessity is looking more at the specific traits of an individual patient. There might be a test that's appropriate for someone with advanced non-small cell lung cancer that isn't going to be appropriate for someone with an early stage melanoma. So that would be a medical necessity or individual patient distinction, that this patient isn't appropriate for this test. But if the test meets the criteria spelled out in the law, it should be covered for the patients it is appropriate for. So I'd say medical necessity isn't an out to never cover a test that clearly fits within the guidelines in the state law. Can you remind me? On the enforcement side, so state insurance commissioners and Medicaid directors have the authority to enforce state laws. And each of these state laws or existing state law establish criteria for patients and providers to file appeals and complaints to elevate if there are problems with compliance. So it is difficult to see, what's happening every day with every patient covered by an impacted plan.
So I'll go back to that medical necessity piece, because I think where we've seen challenges arise is when the sort of sources of evidence listed in the biomarker laws themselves have vague language. I mentioned that when it comes to guidelines, it happens in the LCDs too, where they write, maybe a statement would be written like when it changes the medical management of a patient, right? Like that's an interpretive statement. That's not an objective statement. So then it lands in the hands of a medical director to make the determination about that, which is inherently sort of subjective and based on opinions and thoughts about medical necessity. I think when guidelines or any of the guidance, that is cited in the biomarker law say very clearly, people with this specific ICD code should have this specific test with this specific CPT code, that is much less ambiguous. It's very clear, right, in that case. But a lot of times the evidence is not that clear. And when the evidentiary sources are not that clear and the primary literature is not that clear to support it, it does become tricky. And that's where I think you really do have to fall back to a medical necessity determination for a specific patient, where maybe you do have from their medical record some specific evidence you could draw on to make a better decision.
Yeah, and I'll just kind of add to that. I mean, we sometimes when we're going in and working with a Medicaid plan and we're talking about our specific tests. So, for example, our mental health and pharmacogenomics test is one that we focus on a lot. We'll point back to the LCD, right? As what am I supposed to do with this? Well, you can look to the LCD as you could cut and paste it if you wanted, right? There is something there for folks to work with when that is the criteria. Maybe a little harder when it's guidelines. It might not be as vague. And as you pointed out, Jillian, there can be some vagueness within the LCDs as well. And Brian mentioned that you may be able to get some clarity by looking at a billing article, at least kind of how the Medicare contractor is thinking about it, right? As far as like, oh, this is the list of tests that they think at least applies to that coverage policy. Those are great answers.
And I'll pick up on just the sort of enforcement and then the litigation as
sure.
the lawyer on the call. So, I think the enforcement, I think, as Hillary said, really it's with the divisions of insurance and the Medicaid program. There has been, a lot of question about, what is the appeals process / complaint process. So plans have appeals process, and most division of insurance have either an appeals or complaint process. Many times the division of insurance has language that says a provider or patient must first go to the plan for their appeals process, before you can get to the division of insurance. And I think one of the questions that has come up is many of those appeals process are really meant for like individual patient level appeals. Here, this is more of an appeal of the policy. Does the biomarker policy apply or not? So, many plans will have a test listed as non-covered, that it appears to meet the biomarker laws. And so in those cases, I think there's been a request that, can the appeal be made directly to the division of insurance to sort of, elevate the issue and not go patient by patient? Or can you bundle a number of patients into like one appeal and bring those to the division of insurance? So that really is all, very technical and varies by state. As far as I know, there haven't been any lawsuits. I know some people have looked at the lawsuits. The lawsuits do have some challenges based on sort of state law and federal law. Do you have to exhaust all your administrative appeals? So as I was talking through, like appeal every one of these individual claims. Are some of these issues preempted and you can't sue at the state level because of risk? So I think there's a lot of complex issues, but I wouldn't be surprised if at, some point for some specific group of patients or some tests, you could see a suit filed if it's been 2+ years and tests are still not being covered. Ultimately that is, one of the ways to elevate an issue and get the most attention to it. But I think most people would want to pursue what we're doing here on this call and kind of work it all out and kind of get some clearer guidance and get some policy as opposed to spending a lot of time with appeals or litigation.
Yeah, great. One last question. We can try to get to quickly. If we don't get to your question here, you can email, into the webinar organizer. We are happy to try to follow up with you and get you the information that you're seeking. I know all of you are probably concerned, with biomarker testing, the, under these laws, the increase in coverage. And I know that all of your programs there in the Medicaid plans are facing budget issues in your state and, possibly some pressure from federal money as well. So I know that concern is there. Hillary, could you very briefly just speak to costs and the concerns? I think it's not a sky is falling situation as it might seem on the outset to some payers.
Yeah, I think what's valuable to keep in mind is that often a marginal increase in upfront testing costs can lead to overall treatment savings and improved health outcomes. So there are many studies looking at this, particularly looking at single marker and smaller panel testing, so less expensive testing versus broader large panel biomarker testing, and finding really significant cost savings and cost avoidance by doing the more comprehensive testing up front, and allowing patients to avoid treatments that are ineffective or unnecessary or even dangerous and harmful. So it's not necessarily just going to cost more money because more services or more testing is covered.
Great. Thanks for addressing that quickly and concisely, Hillary. Appreciate it. I think that's all the time we have. Again, if your question didn't get answered and you still, or if one pops up in your head later, please reach out to one of us or to the webinar organizer, and I'm sure it will make its way to us. But I look forward to continued engagement with my panelists on working on these issues, and hopefully everyone here who's on the webinar to see you engaged, so we can help provide clarity and help get to a point where we're doing the right thing for patients across the country. Thanks everyone for joining.
Thank you.